Honor and privilege to stand before you on this auspicious day and welcome all of you to this conference. INVESTICON is a collective venture by 4 departments: pathology, microbiology, biochemistry and radiology, which was started in the year 2022.
We would like to walk you through today's program schedule for INVESTICON 2024. The theme for the year is Unraveling the Diagnostic Tapestry in the Field of Patient Care. We will start with paper presentation by postgraduate students, the rules of which are as follows. Each student will be allotted 4 minutes for presentation and 1 minute for discussion. For this session, I would like to invite Dr. Asitava Mandal sir and Dr. Uttam Kumar Paul sir to judge the session. I would like to call upon the first speaker, Dr. Arushi Khajuria, on stage, who will speak on the topic of clinico-pathological spectrum of cutaneous appendiceal tumors.
Good morning everyone. Myself Arushi Khajuria. I am presenting paper on the topic Clinico-Pathological Study of Cutaneous Appendiceal Tumors. This is the overview of my presentation. Skin and neck cell tumors comprise a wide spectrum of benign and malignant tumors that differentiate towards one or more head neck cell structures found in normal skin. This study aims at finding the clinical and the histopathological features of cutaneous head neck cell tumors. Head and neck region has the richest distribution of pilosebaceous apparatus. Clinical diagnosis of head neck cell tumors is challenging, so histopathology is valuable in confirmation of the diagnosis. A retrospective study was carried over a period of 6 months in the Department of Pathology. All relevant clinical and histopathological features were taken into account. This is the case of nevus sebaceous. It presents as verrucous plaque and microscopically it presents as this large sebaceous glands and epidermal papillomatosis. Next we have the case of syringoma. Clinically it presents as small papules near the lower eyelid and microscopically it presents as multiple small ducts in the dense fibrous stroma, and these ducts are lined by a double layer of cuboidal epithelium. Next we have the case of pilometricoma. It is a deep-seated nodule and microscopically it presents as basophilic matrical cells at the periphery, and it later transition into suprapellar matrical cells and finally give rise to centrally located shadow cells. Next we have the case of tricholemoma. They present as small papules located on face and neck, and microscopically clear squamoid cell with peripheral rim of cuboidal epithelium. Next, we have the case of hydroadenoma. It is more common in head and neck, and tumors are round with eosinophilic cytoplasm. Next, we have the case of syringocystadeno papilliferum. They are located most commonly on the scalp, associated with nevus sebaceous, and microscopically glandular epithelium with inner cuboidal and outer myoepithelial cell. Next is eccrine poroma. They present as pink pedunculated nodule and microscopically composed of monomorphous basophilic cells and the eosinophilic squamoid cell. Next we have sebaceous carcinoma. It is a neoplastic lesion comprising of tumor cells arranged in solid sheaths and lobules showing high pleomorphic activity as well as pleomorphism. Next, a total of 21 cases were analyzed. Out of 21 cases, 20 were benign and 1 was malignant. Tumor cells showing sweat gland differentiation constitute the largest group, followed by sebaceous gland differentiation, then again followed by follicular differentiation. So above data is depicted in the following diagrams. The commonest site of involvement is head and neck, and the results are consistent with the study conducted by Sijikon S. et al. In our study, 95.2% cases were benign, while 1% cases were malignant. And the results were malignant, consistent with the study conducted by Rajalakshmi V. et al. So, in conclusion, I want to say that a discrepancy was noted between the clinical and histopathological findings. Correlation was noted in only 7 out of 21 cases. In our study, we found that majority of the tumors were benign and located in head and neck region. The importance of accurate histopathological diagnosis is essential in these tumors to diagnose the malignant counterparts as well as differentiate them from the other skin tumors. Thank you very much.
If there is suspicious areas, then do you suggest for a whole tumor infiltration by total removal of the tumor along with the line of resections to be free? Do you advise this?
Sir, every malignant tumor has a different line of treatment.
No, not that. Your suggestion at the end of the report. You suggest the clinicians that as I am going getting some atypia or areas suspicious of malignancy, wide excision with resection lines to be free of malignancy. You suggest at the end of the report. I think it is the duty of a pathologist to guide the clinician. That is the only thing that I want to
Your presentation is very good. I have enjoyed your presentation. But what new things you want to improve your study?
defined study, only 7 cases that were clinically diagnosed were histologically correlated. Others we diagnosed it as different tumors. Second, we found that most of the tumors were found in head and neck region and are benign in our study and in this region. Then next, the third point I want to add is that benign we can differentiate on histopathology only is benign or malignant. Then we can advise the management and the line of treatment as early as possible. Thank you, sir.
Achha, any other question from audience? Any from DGs, from faculties? Yes, no question is there. Good.
Thank you, sir.
Thank you, Dr. Arushi. Now I would like to call our next speaker, Dr. Rishu Sinha. She will be speaking on the topic microbiological insights into corneal ulcer, a focus of keratoconus.
जी ठीक
Dr. Rishu Sinha. Here I am presenting a paper on microbiological insight into corneal ulcer, a focus on keratoconus. A corneal ulcer is a corneal epithelium defect involving the underlying stroma, and it is a potentially reason-threatening ocular emergency. It is usually associated with tissue excavation, infiltration, and necrosis. Even with prompt treatment, patient can suffer from significant morbidity with complications like scanning, perforation, cataract, glaucoma, or vision loss. Such keratitis may be occurred by bacterial, fungal, viral. Predisposing factors are ocular trauma, dry eye, vitamin A deficiency, contact lens wear, prolonged use of corticosteroid. Systemic risk factors are malnutrition, diabetes mellitus, immunosuppressions. Common agents for keratoconus are for fungal, aspergillus, Fusarium, Arteriaria, Acrimonium, Calvularia, and for bacterial, Staphylococcus aureus, Staphylococcus epidermis, Pseudomonas aeruginosa, and for viral, it is herpes simplex virus, varicella zoster virus, cytomegalovirus. Now materials and methods. A prospective study was undertaken on 52 patients who came to the OPD of ophthalmology department. Patient with healing ulcer, moron ulcer, and patient who was on the treatment were excluded from the study. Detailed clinical history was taken and previous use of medication was recorded. Material was collected from the conjunctiva, shank area, cornea, ulcer scraping. Scraping was done under aseptic condition by using 4% lidocaine and by using 50 number surgical blade. Material was obtained, was inoculated directly on SDA plates, and 2 smears were made. One for Gramston and one for Kerch mount. Kerch microscopy was completed within 1 hour so that the treatment for keratoconus could be started earlier. For fungal culture, specimen was inoculated into SD plate and incubated in POD at 25 Celsius. It was examined daily for any growth for first week and twice daily
started blue and slide culture. Now result, during 12 consecutive months, 52 patients were seen. Communist age group was 31 to 50 years. Socioeconomic poor class was showing highest percentage of keratomycosis, that is 87%. Common predisposing factor was trauma. Mycotic keratitis was observed in 71.5% cases. Out of this, 37 were positive for fungal Kearch mount. Among this, 29, that is 55.76 cases show pigmented fungi, and 8, that is 15%, show hyaline fungi. 21 cases was positive for fungal culture. In this, we got aspergillus, that is 6, that is 28.7%, Curvularias 4, that is 19.4%, and bipolaris, that is 2, that is 9.52%, Alternaria, that is 2, that is 9.25, and rest was contaminations. Aspergillus grow on SDA plates, and this was a picture of Kearch mount showing aspergillus grow. Now discussion. The present study observed that majority of keratitis case occur in socio-economic poor classes. With, trauma was most common predisposing factors. Our observation of mycotic keratitis is 71.5%, with significant portion showing pigmented fungi. This highlights the importance of fungal identification and target antifungal treatment in managing keratitis. Now conclusion. The study finding indicate that the most affected age group was 31 to 50 years, with affecting socioeconomic poor class. Trauma was most common predisposing factors. High prevalence of mycotic keratitis, that is 71.5%, shows higher with pigmented fungi accounting for 55.76, and hyaline fungi, that is 15.38%. It emphasizes the critical role of accurate and timely microbiological diagnosis in managing keratitis. Thank you.
You are from Department of Microbiology. So all these corneal ulcer cases you have collected from ophthalmology department.
Yes, sir.
So, and most of the cases, 71% cases are fungus. Do you know how they treated these cases?
Yes, sir.
Huh?
On the slit lamp.
No, they have diagnosed. How they treated?
Yes, sir.
What is the treatment of this fungal
For the
corneal ulcer?
filament fungi, they use natamycin 2%, amphotericin B, and itraconazole. And orally, they give fluconazole, posaconazole.
Yes. So, have you any data regarding the how many patients cured after treatment, how many not cured?
Sir, we have very few less follow-up cases in my department.
Okay. Sir.
Characterize the fungus, what type of fungus they were. Only they have told filamentous or pigmented. Have you characterized them?
Yes, sir.
What were that common types, the fungus that you have faced?
Sir,
Apart from aspergillus.
Fusarium species.
Only fungal lesions in the eye without any systemic involvement. All these patients have only fungal lesions of the eye without systemic involvement.
So they are, the systemic risk factor was diabetes, and mainly they are agriculture worker. And this was the phase of harvesting. The harvesting phase.
Have you done the immunocompromise of this patient, whether they are suffering from HIV?
Yes, sir, I got immunosuppression.
Because this is very important. If they are
Yes, sir.
immunocompromised, fungal lesions occur.
Yes, sir,
And
I got.
usually they present with systemic along with orbit. But localized orbit, have you ruled out dacryocystitis or blockage of the drainage of the eye wall? Because if it is not drained, then the fungal lesions will grow more.
No, sir.
You have not done. And
No,
the immunocompromised, whether you have not done the HIV or other status.
Yes.
Have you done those status of the patient?
No, sir. So actually, follow-up was not
No,
done.
what I suggest, the paper is good, but only two to three things we have to do. Characterize the fungus properly. What
Okay, sir.
types of fungus? Number two, you do the immunocompromise of the patient, HIV or other status, because they suffer more. Number third, we have to rule out dacryocystitis because there is a blockage, lacrimal duct, these areas. Usually those areas, if it's blocked, then it will not be cured.
Okay,
So
sir.
these 3 areas you take proper care.
Yes, sir.
Thank you.
Thank you.
Thank you, Dr. Reshu Sinha. Next, I would like to call upon the next speaker, Dr. Amiteshwar Singh Randhawa. The topic is Assessment of Ultrasound Characteristic, Incidence, Age and Sex Distribution of Superficial Soft Tissue Masses, a comparative study with existing literature.
Good morning, everyone. I myself, Dr. Amiteshwar Singh Randhawa, Department of Radio Diagnosis, MGM Kishanganj, going to present a paper on title to assess the ultrasound characteristic incidence, age, and sex distribution of various superficial soft tissue masses presented over a USG department and compare them with the literature. I done under the guidance of Dr. Rezul Karim, our HOD, and our AP's introduction. Soft tissue tumors are not uncommon, with most common being benign. Several imaging modalities have been used to assess soft tissue tumor following physical examination, including plain film, nuclear medicine, high resolution ultrasound, computed tomography, MRI, angiography, and pulse emission tomography. Although many reports state that high resolution ultrasound cannot differentiate benign from malignant tumor, high resolution ultrasound does have high sensitivity in detecting tumor. Recent advances in ultrasound technology have enabled the ecotexture of soft tissue tumor to be presented in greater detail. In this study, I would like to review the characteristic features of various soft tissue masses presented to our USG room and compare them with the literature. Aim of the study to assess the ultrasound characteristic incidence, age, sex distribution of various superficial soft tissue masses presented to our ultrasound department and to compare them with the literature. The sample size was approx 60 cases. Study period is 6 months and type of study is hospital based. Inclusion criteria will include all the patients of all ages and both sexes. Exclusion criteria will include patients with breast, thyroid and scrotal swelling. Methods and materials. We include 60 patients with superficial soft tissue masses who are referred to our ultrasound room and mainly from general surgery and orthopedics department and others. We included the patient of all ages group and both sexes. We examined all patients with high resolution ultrasonography with high frequency linear probe and also convex probe, and also we used color Doppler to assess the vascularity. Various features such as consistency, shape, size, margin, location, vascularity, relationship with the adjacent structure are assessed. Then we characterize them based on their characteristic and arrange them based on their incidence. Most of the cases were confirmed by either preoperative FNAC or postoperative biopsy. Results. Out of 60 patients, the incidence of soft tissue masses are like lipoma, 12 cases, and then in decreasing order like lipoma, fibrolipoma, sebaceous cyst, dermoid cyst, abscess, boil, ganglion cyst, neurofibroma, cystic hygroma, rhabdomyosarcoma, schwannoma, and pseudoaneurysm. This on the left side of screen, there is lipoma of chest wall. Then there is sebaceous cyst, which we also say the epidermal inclusion cyst of right gluteal region. Then dermoid cyst of right ovary, sebaceous cyst of right axillary region, boil in the scalp region, ganglion cyst of the wrist. Neurofibroma of brachial plexus, right side cystic hygroma in newborn, rhabdomyosarcoma of anterior abdominal wall, schwannoma of median nerve, traumatic pseudoaneurysm of superficial temporal artery. Age and sex distribution, USG features of various soft tissue swelling in my study is comparative with the literature. This is a chart we got result. In lipoma, the most common cases, a total 12 cases we got, and male predominance with male predominance. And mostly, most common age for in literature is 40 to 60, and my study also it is approx 40 to 50. Then fibrolipoma, total 7 cases. Then male is more common than female, and like all the fibrolipoma, sebaceous cyst, dermoid cyst, abscess, boil, ganglion cyst, neurofibroma, cystic rhabdomyosarcoma, schwannoma, all are almost equal, goes with the literature. And on the right side, there is normal consistency echogenicity pattern in the USG I have written. Discussion. Superficial lesions are sometimes very small and located on the dermis or in the subcutaneous layer. Several ultrasonographic parameters are used to evaluate peripheral soft tissue masses such as echogenicity, margin, morphology, composition, size, vascularity, and other specific patterns. High resolution ultrasonography enables differential diagnosis among ganglion, gangliocyst, neurofibroma, lipoma, schwannoma, epidermoid cyst, tenosynovitis, bursitis, hematoma, abscess, and pseudoaneurysm. High resolution ultrasound also useful modality in detecting soft tissue tumor and differentiating benign from malignant. However, histopathological examination being the gold standard. Limitations are in my study, as my study is studies a case series of study with limited sample size and small study period. The rare swellings were not reported, and also our characteristics of even swelling are not reported. Conclusion. In my study, among various superficial soft tissue, swelling lipoma being the most common one, and followed by sebaceous cyst, dermoid cyst, abscess, furuncle, and least reported were being the pseudoaneurysm, cystic hydroma, rhabdomyosarcoma, schwannoma, and neurofibroma. And almost all the soft tissue masses characteristics are almost similar to the ones classically explained in the literature. Rare presentation of masses are not reported in my study, as my study is of limited study period with limited sample size. Reference, these are reference. Thank you.
It is a good paper, but can you go back to the photographs of ultrasonography?
Yes, sir.
This sebaceous abscess that you have shown over here.
Yes.
But see, this is encapsulated. I think it is infiltration of the soft tissue.
Sir,
Lower part, if you see, these are the surrounding areas. It is going deeper areas. Have you done the FNAC and have come to the conclusion that it is a sebaceous?
Second film or a fourth film?
Sebaceous abscess of the right axillary region. Others is okay, but that part I want.
Yes, sir, it is confirmed FNAC, because on ultrasound its closed differential abscess.
But see the lower part of the abscess, it is infiltrating the deeper tissue. So sebaceous abscess should be encapsulated, but deeper tissue, I think there is infiltration. Why there is infiltration in the deeper tissue?
Sir, according to us, I think it's early stage of sebaceous abscess.
These cases you do what I feel is colored Doppler.
Yes, sir.
Colored Doppler will help. Colored Doppler in soft tissue tumors, colored Doppler in benign and malignant, they clear cut give some indications.
Yes, sir.
And these photographs are good, but if you combine these photographs with your colored Doppler, by the side in the upper part of these areas will give better impression.
Yes, sir.
The work is good, you carry on with the work, but one thing I suggest you, correlate with the FNAC.
Yes, sir.
Ultrasound correlate with FNAC, and
yes,
you find what are the false positive or false negative report.
Yes,
and if necessary, then you can go for other investigations.
Yes,
after this, do you suggest any other imaging studies, or you,
yes, sir,
you suggest only excision and histopathology?
Sir, in our department, we correlate with most commonly with the MRI, sometimes with CT.
But why you suggest do MRI in this case? If you suspicious of soft tissue tumor, you do, but once it is benign or other things, then no use of doing MRI in
sir,
this
like
cases.
Sir, if we have confusion with epidermoid cyst, epidermal occlusion cyst, and dermoid cyst, then we will see diffusion restriction in epidermal occlusion cyst on MRI. This is a very differential point.
Okay, thank you very much.
Thank you, sir.
One query.
Yes, sir.
What is your topic?
Sir, my topic is the daily basis we do ultrasound. We see cases. Is it core?
The name of the topic, title?
The title is to assess the ultrasound characteristic, incidence, age, and sex distribution of various superficial soft tissue masses.
Okay.
Yes.
Superficial soft tissue masses.
Yes,
And
sir.
you have shown the picture of right ovarian dermoid cyst.
Yeah. But
That's
sir,
just the picture.
actually, sir, the dermoid cyst was a little bit.
It is not a
palpable.
superficial soft
No.
tissue mass.
It is not superficial.
Okay.
Thank you.
So from the
Hmm.
figures, ultrasound pictures एक बार दिखाओ.
Mhm.
Right. Right upper corner.
Yes, sir.
It should not be included. I
Yeah.
think so.
Uh-huh.
Sir, your comment.
Yes, all the USG, and you have done high resolution USG.
Yes, sir. High resolution linear probes.
This machine is here. in
Yeah,
our
we have.
center,
We
high
have, sir.
resolution. It is the normally USG machine. Is it done in normal USG machine, or high resolution USG machine is different from that machines?
Okay, sir. We have up to 12 frequency probe. 12 frequency, 12 hertz frequency.
Okay.
Thank you.
Dermoid cyst or ovary. You could have told it is a huge dermoid cyst pressing on the abdominal wall,
Yeah.
and we think whether to exclude it from other parts.
So that's why
That will be your question to defend the question.
I was
See,
giving-
if you see the dermoid cyst in the abdomen proper, then paper does not justify. If you see the dermoid cyst which is upper part and this appendiceal area or colonic area that is coming superficial,
Sir, this
then that area you could have highlighted. I have got these cases.
Sir,
I
the-
think
this
that answer would have justified his question.
Sir, I was giving the same answer that it is palpable per abdominally. And the ovary is little bit situated to the colic side, carotid. Yeah.
Thank you.
Thank you. Okay. Thank you, sir.
Thank you, Dr. Randhawa. Next, I would like to call our next speaker, Dr. Gurpreet Singh, who will be speaking on the topic role of MRI in CNS infection.
Hello, good morning everyone. My name is Dr. Gurpreet Singh. My topic for today's paper presentation is role of MRI in CNS infections under the guidance of Professor Dr. Lizaul Karim and Professor Dr. Satish Pathak, Dr. Rituparna Das, Dr. Vijay Kumar Yadav. Introduction. Infections of the central nervous system are important cause of morbidity and mortality worldwide owing to their life-threatening complications. Today, with the availability of excellent antimicrobials, many of these disorders are potentially treatable, making early recognition imperative. MRI has revolutionized the manner in which diagnosis is made. Infections due to various pathogens are associated with a variety of neuroimaging patterns that can be appreciated at MRI. Knowledge of common imaging patterns and potential complications of CNS infections is critical in prompt diagnosis, which can minimize adverse outcomes. Aims and objectives of my topic is to study the characteristic MRI imaging features of various CNS infections, to see the correlation between the clinical laboratory and radiological findings. Materials and methods. Source of data. A hospital-based observational study was conducted over a period of 21 months, April 2022 to 2024 January, in Mata Gujri Memorial Medical College, Kishanganj. Inclusion criteria for the topic is 45 cases of any age group and both sexes who were clinically suspected, previously diagnosed for CNS infections and willing to take part in this study were randomly enrolled. Exclusion criteria. Patients who refused and cannot undergo MRI imaging, such as patients with non-compatible prosthetic implants, pacemakers, claustrophobia, and uncooperative patients. Methods of data collection. After taking an informed consent from all the subjects, guardians, a detailed clinical history with special consideration to neurological examination and relevant laboratory investigations wherever necessary were taken. MRI was performed using a Senza Siemens machine of 1.5 Tesla. Protocol consisted of localizers in coronal, axial, oblique and sagittal plane. After proper positioning of the patient, the following sequence were used: T1 weighted images, T2 weighted images, flare images, T2 flare images used, the diffusion weighted images including the ADC images, contrast enhanced T1 weighted sequences, susceptible weighted imaging wherever applicable, and the MR spectroscopy wherever applicable. The positive findings were analyzed. The results were CNS infections were almost equally distributed among males 51% and female 49%, and were mostly found in age group 1 to 20 years. Mostly we got the cases of neurocystic sarcosis 40% of case and tuberculosis 37.77% were the two most common CNS infection diagnosed followed by pyogenic in 8% and viral in 2%. There is a chart showing that number of subjects were positive for neurocystic sarcosis 18 patients 40%, tuberculosis number of subjects 17 and the percentage is 37.7%. Pyogenic number of subjects 8 percentage 17.77%. Viral infection includes two patients in which the percentage is 4.44 and the total subjects were on the which the study was conducted were 45. Among 18 patients, 40% patients of neurocystic sarcosis got colloid vesicular stage was that is the second stage. Most commonly observed findings in 9 patients and 3 subjects showed disseminated NCC showing overlapping of stages. Stage 1 vesicular number of patient 1 colloid vesicle we got 9 patient, granular nodular stage we got 3 patient, calcified nodular we got 2 patient, and the overlapping of stages we got 3 patients. Among the patients of CNS tuberculosis, tuberculomas, leptomeningeal enhancement and enhancing basal exudates were most common findings in the patient who are suffering from the tuberculosis infection. Among pyogenic etiology, leptomeningeal enhancement was most commonly seen, followed by infarcts and hydrocephalus. The imaging pattern infection in which there is enhancing basal exudates, the number of patient includes the tubercular infection showing the basal exudates enhancement that are 6, and the tuberculomas that we got that patient having tuberculomas that are 16, and along with that there is the leptomeningeal enhancement, the patient were 10, and the patchy meningeal enhancement, one patient is there, along with the hydrocephalus 4 patients. Subjects diagnosed with NCC who were put on antihistaminic steroids were followed and showed in clinical improvement. Patients suggestive of tuberculosis infection on imaging correlated well with the clinical history and laboratory parameters. Mean CSF glucose in my study was lowered in pyogenic 42 milligram per deciliter infections when compared with the other groups. Lymphocytic pleocytosis was seen in viral and tubercular group. Polymorphonuclear pleocytosis were seen in pyogenic group. In the viral, which was mostly the diagnosis of exclusion, mean CSF protein is 70.1 milligram per deciliter was slightly raised, and the mean glucose 61.1 milligram per deciliter was within normal limits. Discussion. Neurocystic sarcosis. Patient who presented with seizures and headache presenting complaint and on MRI revealed neurocystic sarcosis. No further laboratory investigations were done. 3 of these subjects had overlapping over various stages on neuroimaging. We found colloid vesicular stage was most commonly observed in 9 patients. Tubercular infection. MRI findings in tubercular infection revealed the meningeal enhancement and as most frequent finding. Other finding was ring enhancing granulomas. These findings corroborated with the study by this in which they found a meningeal enhancement in up to 90% of cases, along with the feature of tubercular meningitis. In the pyogenic etiology, the patient with the pyogenic meningitis shows leptomeningeal enhancement in all cases. Pachymeningeal enhancement was not seen in any of cases. Paucity of pachymeningeal enhancement is in pyogenic meningitis correlates with the study of Kumar et al. In 1995. Along with that, we also got the patient who having the infarcts were seen in 3 patients associated with the hydrocephalus. Viral etiology. 2 patients presented with high-grade fever and altered sensorium. MRI revealed bilateral symmetrical thalamic involvement in both the patients, along with the leptomeningeal enhancement was seen in one of the patient. Conclusion: in our study of 45 patients, most of the patients either had neurocystic cirrhosis or tubercular infection of CNS. Pyogenic and viral infection were less common, and fungal infection was not seen, suggesting MRI findings correlate to a larger extent with clinical and laboratory investigation. Hence, we conclude with with the use of conventional and advanced MRI imaging techniques such as diffusion studies, we can analyze the characteristic imaging findings and narrow down our differentials. Thus, being non-invasive and less time-consuming, MRI can a modality of choice in management of CNS infection at present in the time to come. Thank you so much.
The paper is good, but I think what we have done is that from the very beginning, not to show so much data, but how you are doing MRI, what is T1, T2, those things are not needed. You directly go on the MRI slides, show the cases, and then discuss.
Okay, sir.
That would have cut down a lot of time. Number two,
Okay,
in
sir.
cases of the abscesses or the infective lesions,
Yes, yes.
do you face any problem with glioblastoma multiforme with necrosis in the tumor and infection? Because these cases really create problem to the neurosurgeon. They cannot, sometimes they have lot of problem in diagnosis. They go for, nowadays they do not go for open biopsy of the vein, they do stereotactic biopsy. Stereotactic biopsy, immediately if you do a squash or anything, they immediately tell whether they dealing with infection or a tumor, and accordingly they go. But have you find any problem in these cases? Because your cases, you have shown straight cut cases.
Yes.
Tuberculoma
Yes.
is easy, but
Yes,
tubercular abscess is difficult.
Sir,
So,
actually,
number one question. Number two question, in cases of extensive abscess, do you find a shift of the midline?
yes, sir.
If you find a shift of the midline, there is a wrong suspicious that you are dealing with a malignant tumor. Usually shift of the midline is a very acute condition, patient needs surgery. And number third, have you done MRI with angiography combined? MRI with angiography has lot of tell whether the tumor is malignant or you are dealing with an infection. These are the three things. Not a query, I want to ask whether you have what you have felt with those things.
Sir, actually, the answer for your first question is that we can differentiate the malignancy and the multiple tuberculomas, tuberculoma and the CNS brain infection. They have some different imaging features and differentiating points in the glioblastoma multiforme, as you said. With necrosis, yes, with central necrosis, we can confuse with the stage tuberculoma third, in which there is caseating granuloma with center liquefaction, that center necrosis. According to that, the edema in the glioblastoma multiforme is much more, and the midline shift is much more in that, and it crosses the midline, glioblastoma multiforme, and forming the butterfly shape. And in the tuberculomas, there are consistent so they are combined tuberculomas along with the in that stage, third stage, there is not so much edema in the tuberculoma third stage. If we confuse with that stage,
Lot of practicing those cases of brain lesions with squash.
yes.
When the true cut did not come in Calcutta,
Sir,
I
we
used
can
to practice, but there are a lot of difficulties. Even in case of glioblastoma with multiforme with
Yes, sir.
necrosis,
Yes,
it's
sir.
very difficult to get the malignancies. A lot of necrosis comes out.
Sir,
So, have
according
you
to-
followed up the cases with
Yes,
open
sir. I
surgery?
follow up, and according to that, we started the anti-tubercular drugs. The patient improved too much.
Uh, the, is it a clinico-pathological study?
Yes,
This
sir.
is.
Yes, sir.
So clinicians tell you to do some investigation.
Yes, sir.
Now, if the clinician tells you to do CT scan,
Yes, sir.
how do you convert it to MRI? Do you talk to the clinician? This is a better diagnostic tool.
Yes, we will talk to
What
the
is your
clinician.
duty at that time?
Sir, with the help of the clinician who have told us to do this, we do the
Please
proper
communicate with
communicate
that
with that
clinician because that involves a lot of money
Yes.
in private sector. So
But in our
You have
center,
to.
sir,
In our center, it is
yes, sir.
that is a different issue.
Yes, sir.
But outside, okay.
Yes, thank you.
Thank you, sir.
Of growth should be noted because they are important for brachytherapy planning. In conclusion, the sensitivity of MRI to detect stage 4 lesions, which is almost 100%, is maximum, which is followed by stage 3 in our study, which came out to be 87%, and stage 2 was 33%. However, there is no role of MRI in stage 1 tumors. Thank you. So, Dr. Amol Preet Kaur.
Your paper is on role of MRI in staging carcinoma cervix.
Yes, sir.
But you have done MRI only in the cervical, limited to the cervix region. But you have not shown any local lymph nodes.
Yes, sir.
That is very important. Now, in majority of the cervix cancer that you have shown is almost fungating or bleeding, involving the endo, ectocervix, all. But if you do not include in the pelvic region the other ovaries involved or not, lymph node involvement not, whether it is operable or not,
Yes,
those areas should be highlighted in MRI. MRI is very costly test. And this MRI is almost not needed if you have this such a huge growth in the cervix. Ultrasonography is sufficient. But if you do MRI, I think it should go up to even up to the umbilical region.
Yes, sir.
To see whether the involvement of the structures, whether there is operability or not. So that is my suggestion.
Yes, sir. So we'll consider that when we do further evaluation for such patients.
So it is not a paper on staging. It is rather a paper on diagnosis of carcinoma cervix.
Yes, you have presented within time. But what is your study period?
So I just did a retrospective study and considered cases which presented to us over the past 1 year. And
In the
retrospective.
past 1 year, you have got 30 cases of
So it's
cervical cancer in this institute.
so ultrasound, I got many cases, and retrospectively, I also included studies which were happening here. So this place has a lot of patients which go undiagnosed, and they come to us at very advanced stages. It is very rare that I have seen very early stages here.
Questions from audience? Okay, thank you.
Thank you, sir.
Thank you, Dr. Saini. Now I would like to call upon Dr. Himanshu Verma, whose topic is role of MRI and radiologist in evaluation of compressive myelopathy.
Good morning. My title is Role of MRI and Radiologist in Evaluation of Compressive Myelopathy. I did this paper under guidance of Dr. Professor Rizal Karim and Dr. Rituparna Das. Introduction. Compressive myelopathy is the term used to describe the spinal cord compression either from outside or within the cord itself. Compression may be due to herniated disc, post-traumatic compression by fracture or displaced vertebra, epidural hemorrhage, abscess, or epidural or intradural neoplasm. A spinal cord injury is the main cause of quadriplegia and disability. Plain radiograph have a low sensitivity for identifying traumatic spinal lesions. Therefore, trauma victims with plain films negative for a spine injury but with a high clinical suspicion of injury or positive for a spinal injury should undergo MR for definitive evaluation of the spine. To evaluate the role of MRI in delineation of various etiologies of compressive myelopathy of the spinal cord, these are the aims and objectives of my study. To characterize these compressive lesions according to their anatomic location and correlate with the clinical findings. To to classify the lesions based on location into interdural and extradural or intradural compartment. To study the MR signal characterized of various lesions with histopathological correlation wherever is possible. Material methods are: the data for this study is collected from the patients referred to MRI scan to our department. Patients who are clinically suspected as a case of compressive myelopathy are investigated with MRI. These are the criteria for the case selection. This study group includes total sample size of 32 patients selected by purpose of sampling method. The data is analyzed by descriptive analysis. Sequences done for all these studies are T1 weighted, T2 weighted and Aster's sagittal, T1, T2 weighted axial and GRE axial, post contrast T1 weighted axial, sagittal and coronal images. Result of my studies are unstable fractures and stable fractures are barely 5% of the total data collected, and most of the cases are epidural hematoma and soft tissue component in the area of spinal cord. When we compare with the when we consider the location of the lesion, then the cervical region is the most common site of the lesion, including 58.3% of the total cases, and following that thoracic region is the second most common region, including 41% of the total cases. Traumatic myelopathy include approx 37% of the total cases causes the compressive myelopathy, and after that following that 25% is included in infection of tuberculosis. After that neoplasm, primary neoplasm includes 21.9% of the total cases. So summarizing the all of the cases, traumatic myelopathy is the leading cause for the compressive myelopathy, and infection after that infection of the tuberculosis, it comprise 85% of the total cases, excluding from the non-traumatic cases. We used to correlate our data with the histopathological examination in few cases. We haven't done each and every follow-up cases and correlation with histopathological data because we can't do each and every histopathological examination in all these cases. These are the few images done for our cases. Flexion distraction injury at D12 and L1 level causing cord compression is shown in the first case, that is the case of traumatic myelopathy. And second one is the burst fracture involving the L1 vertebra with multiple fracture line with fractured L1 vertebral fragment compressing the thecal sac and cord conus complex. This is the case of TV spine with cold abscess formation. There was a diffuse irregular heterogeneously enhancing altered marrow signals intensity of D8 through L1 disc vertebral level, including their posterior element appearing heterogeneously hyperintense on T2 image and hypointense on T1. Conus complex opposite to D10, D12 level resulting in reduction of a spinal canal reserve and cord conus edema was there. This is the case of meningioma. Homogeneously hyperenhancing intradural extramedullary soft tissue lesion was there, and this lesion was situated at C1 vertebral level. Conclusion of this study was MRI is the best modality to evaluate cord edema or contusion and integrity of the intervertebral disc and ligaments. MRI is the very sensitive and considered the imaging modality of choice to detect and characterize the spinal tumor and spinal infection. The final diagnosis still relies on biopsy and histopathological examination. Till date, MRI is the only modality to directly image the spinal cord. In our study, with the help of MRI, we could successfully characterize the spinal cord based on location into extradural, interdural, and access the integrity of a spinal cord, intervertebral disc and ligament with acute trauma. So we can conclude that MRI is the very definitive, sensitive and accurate, though costly, but very specific, non-invasive, radiation-free modality for evaluation of compressive myelopathy. Thank you.
The paper is quite good. We have done compressive myelopathy. Only thing you have to do by MRI. CT is not much of use. But in MRI compressive myelopathy, where everywhere surgery is needed, because if you keep the patient for long, then the spinal cord pressure will be there and you will lose it. So it is not difficult to get the biopsy of this compressive myelopathy, number one. Yes. Number two, in case of metastasis that we found, do you have already known primary metastasis or it is an unknown primary with metastasis? If we do not find a primary site of metastasis, then how will you assess that it is a metastasis in the vertebra and the adjoining area of spinal cord? Or do you find in malignancy multiple metastasis or solitary metastasis?
So we used to find most commonly multiple metastasis, and for that we just can't confirm those metastases through histopathological examination, but we just conclude it may be due to by radiological images and different type of sequences. We just conclude that it may be a metastasis lesion.
If you find, suppose you are suspicious of a metastasis in the vertebra and adjoining area of spinal cord involved, so do you do a routine X-ray or routine, because majority of the areas that we find is in the prostate, uterus, lung, intestine, kidney. These are the areas where metastasis occurs in
yes,
the
sir.
bones. So if you do even a routine ultrasound of these areas, it will help to locate.
Yes, sir, we used to do. We used to assess abdomen and to locate the metastatic sites, such as in liver and lungs involvement are common, and we also used to take HRCT of few cases to just to locate either it got metastasized to lung or not.
From lung or not?
Yes, sir.
And if there is extensive metastasis, you can go for a TrueCut or an FNAC, because these are the areas of vertebra involvement, and some of the cases there is soft tissue or this area. To put a needle over there is not difficult. If you do a guided area,
yes, sir.
Because I am practicing this for a long time, the vertebral lesions destruction with guided FNAC, you get lot of material from those areas.
Yes, sir. When it is in posterior compartment of the spinal cord, we used to do it, but if it lies in anterior compartment, we just can't do, sir. Yes, sir. Okay, sir. Okay, sir. So considering the time duration for the paper presentation, we have just limited the number of images. Okay, okay. Thank you, sir. Thank you.
Okay, thank you. Next.
Thank you, Dr. Verma. Now I would like to call upon our next speaker, Dr. Anmol Guman, who will present the topic foreign body impaction in esophagus.
Good morning all. Today I am going to present a topic on paper presentation on foreign body impaction in esophagus. Introduction. Foreign bodies are one of the most commonest emergencies in ENT. Ingestion of foreign bodies are accidental. Common foreign bodies